Good morning and welcome. I'm Pascal Spothelfer, Genome BC's President and CEO, and I'm delighted to open the 2021 Genomics Forum. I would like to acknowledge that I'm talking to you from the unceded traditional territories of the Coast Salish people, including the territories of the Musqueam, Tsleil-Waututh, and Squamish nations, where I live and work. This year, adjusting to the virtual format of our Genomics Forum, we have chosen a 3-day format with sessions spread over the day to give you more scheduling freedom and the opportunity to recover between the virtual sessions on this platform. Each day takes a look at aspects of the COVID-19 pandemic with a different lens. We have taken full advantage of the nature of these sessions, of the virtual nature of these sessions, by assembling an outstanding group of regional, national, and international speakers and panelists. This is also my opportunity to introduce you officially to Dr. Federica Di Palma, our Chief Scientific Officer and VP Sectors. Federica has joined our team, mostly virtually, in the fall of last year and has made us a better organization already. She will be your host for most of this first day. Now it is my pleasure to ask Elder Lillian Howard for her traditional Indigenous welcome. Enjoy your day. Thank you very much.
Good morning, everyone. It is a pleasure to be here and a privilege to be here, an honor. And Uklashi is Nahamius, who's actually Tsiukwat. She's Moachat Nuchalos Klinkit Kwakwayakwak, who's actually Tukwitikumsat. My Moachat name is Nanahamis. The house I come from is the house of Tuquiticums. And first of all, Tlako, Wamasis, Musqueam, Tsleil-Waututh, Squamish. And it's very important to acknowledge the respective homelands that you're in. I know that we are on an international platform right now, and it's a pleasure to be in a room full of very impressive, prestigious, knowledgeable people who are working hard to find solutions to the global pandemic that we are in. And it's extremely challenging and hard for so many families globally. And I'm really delighted to see that there is such a group of committed people to addressing this, a very serious issue. The global pandemic we cannot take lightly. It affects not only people, but the environment and how we look after ourselves and how we look after the respective lands that we choose to live in. As we know, we are aware that prior to human contact, that the lands were the homelands of Indigenous peoples, diverse groups across the country. And it's a teaching that we have. For example, my teaching comes from Hishikistawak. All is one. The earth, the universe is all interconnected. And we need to look after every aspect and component of the earth or the world that we live in. And we have a responsibility to take care of the land and the environment, the people who share the lands. And it's really important also to have Isak, what we call in my language, respect. Respect for self, respect for family, respect for community, respect for the lands, the waters, the resources, and to be very careful about how we walk on to shorten with Mother Earth. Each and every one of us has the responsibility to look after each other, to look after the lands and the waters. And I'm very grateful that I have the opportunity to live in the homelands of the Musqueam, Tsleil-Waututh, and Squamish. It's really important to acknowledge the respective Indigenous nation that you're living in, to work and play and choose to live. We have people from globally from every corner of the world living in Canada now, and Canada is a very young country. And so I want to say thank you for your commitment, your hard work in addressing the COVID-19. I know it's up and down. I work part-time with the Public Health Services Authority, so I make sure that I keep on top of what is going on. I just want to raise my hands up to you all and say tlako, tlako, kelikasla for the important work that you are doing. Your work is not going unnoticed. The Indigenous community is very hit hard by it. Families and community and our culture, we're very culture-oriented people, and singing and dancing, we can't do that. So, and I want to say all the best to you and your families, and the good work that you're doing. Chu tlako tlako kelikasla. All my relations.
Good morning, everyone. Welcome, and thank you so much for investing your time with us this morning. We have an amazing program where we will dive into the importance of genomics in the pandemic, and in particular, the importance of genomic surveillance. What is it, and why do we need it? These are the questions to which I hope we'll find the answers throughout our program this morning. It is my absolute pleasure to introduce to you two very distinguished scientists for our keynote this morning. I'd like to introduce you to and give a warm welcome to Dr. Stacy Gabriel. He's the Senior Director of the Genomics Platform at the Broad Institute of MIT and Harvard, and an Institute scientist. Under Dr. Gabriel's guidance, the Genomic Platform operates as one of the largest sequencing centers in the world and continually explores, validates, optimizes, and implements new technologies, methods, and analysis to meet the needs of the community. Stacy and the member of her team are committed to pushing the boundaries of the genomic frontiers through the application of operational excellence, advanced process design, data analysis, and visualization and technology development capability. And she's here with us today because she has been leading one of the largest non-commercial testing efforts in the US for COVID-19. I'd also like to welcome Dr. Bronwyn MacInnis, the Director of Pathogen Genomic Surveillance and an Institute Scientist in the Infectious Disease and Microbiome Program at the Broad Institute of MIT and Harvard. She also co-leads the Broad's multidisciplinary Global Health Initiative and is a visiting scientist at the Harvard Chan School of Public Health. Currently, Dr. MacInnis is co-leading the Broad's large-scale COVID-19 genomic surveillance effort, working very closely with the Massachusetts and other state departments of public health and the US Center for Disease Control to monitor variants of concern and to track the evolution of the spread of SARS-CoV-2 in New England. She also supports COVID sequencing efforts in Nigeria at one of the Africa CDC 3 resource centers for genomic surveillance across the continent. Welcome both.
Thanks, Federica, and thank you all for the wonderful invitation to be here today. I'm going to share my screen with you now. So the first part of the story I'm going to tell you about today is probably not so much genomics, but it's how we converted a genome center to a massive testing lab. And you can think of it, I think, as a sort of an unexpected outcome of the Human Genome Project and having a genome center around and operational. We were able to accomplish this massive scale up of testing to really, I would say really with the goal of enabling access to high scale affordable testing. And we did so by applying all those same principles we've used as a large scale sequencing operation, principles of industrial work design, of efficiencies of scale, of high quality, and of fast turnaround. And we've been applying these sort of same principles since the days of this photo that was taken during the Human Genome Project over 20 years ago. And really this testing was able to take off because of that. So let me show you a view of where we are today. This is a dashboard that is updated about every 20 minutes that's available through the Broad website. We've performed almost 18 million tests here at the Broad Institute. We have a capacity right now of around 150,000 tests every day. And you can see that we got started end of March. We had a low scale operation for a while, and it really took off over the summer. We serve over 1,200 different users or sites, and these include sites that the state of Massachusetts set up for communities, nursing homes, hospitals, congregate care, employers, colleges, universities, and also public schools. We have always priced this test with a nonprofit motive. We're a nonprofit research institute, so we price this test at $25. We return results within 24 hours. To do this, we have hired over 375 people since May. We've also been testing our employees. Most of those people who come to the Broad are tested 2 times a week, but we test our testing lab every day. In addition, a couple new things to our activity. We have a pooled testing operation going, again, supporting the K through 12 schools. So we've already produced data for about 80,000 pooled COVID samples. And at the end, we'll tell you way more about the viral sequencing. So we're right now sequencing 2,000 different virus samples every week, on our way up to way more. And this is what Bronwyn will also be speaking with you about. So why a Genome Center? Why were we enlisted to do this? Why were we needed? So this is just a table I take from March 8th of last year of 2020. And testing was really going poorly here in the US. As of March 8th, the whole country had performed something like 1,700 COVID tests. It was on March 9th that one of our faculty members, an infectious disease doctor named Deb Hung, called me up and said, "Stacy, the Broad really should take this on. You have a clinical lab, you have massive capabilities at sample handling. Why not take on this testing?" So the very next day, I did pull my leadership team together, and this was on March 10th. And we looked at what this assay was. It's an RT-PCR assay. The CDC had developed a version of the assay, and so we looked into that and created a modified version of it. At that time, there was really massive supply chain problems accessing a lot of these materials. So we made a very big and strategic move early to design around the known supply chain challenges and sort of create our own renegade supply, which I'll show you in a few slides. We rapidly built out new space, mindful of all of the biosafety requirements, and we built a new system for LIMS and returning results to patients. We rapidly completed a clinical validation study so that we could apply to the FDA for an emergency use authorization, that's an EUA, so that we could begin testing. And all of this was accomplished in 2 weeks' time, from March 10th to March 23rd. And March 23rd is the day we launched our testing. The test itself is relatively simple. It is a modified version of this CDC-developed RT-PCR assay. In this assay, we are essentially checking for the presence of 2 viral probes from the N1, N2 genes, as well as a human control in every sample. So it's an RT-PCR test, and for those who aren't familiar, it's relatively simple. We detect the virus and the human control by looking for amplification of it. So we're looking for copies being made in this PCR reaction. And when a copy is made, when enough copies are made, I should say, a fluorescence signal is released and detected on the machine. Now, it's an interesting test and a challenging test in ways, because there's a huge dynamic range over which the test can detect an amount of virus. So if there's a lot of virus around, you get a fluorescence signal very early after a handful of a number of cycles of PCR. If there's not much virus around, it takes longer. And so you won't get a signal till a later point in the reaction. Both of these results, whether you have a signal at 8 cycles or you have a signal at 40 cycles, are called a positive for the COVID virus. And here I'm showing you a distribution of this value of the number of cycles is called the CT count. So I'm showing you a distribution of CT count. And again, we detect very low numbers, very low CT values, which means very high copies of the virus, as well as very high. The reason for this bimodal distribution is not clear, but it's rather consistent, and we keep seeing it over time. Now, this is really important because it really speaks to the very high sensitivity of this assay and why some people will test positive for a very long time because there's not many copies left, even though the person may no longer be infectious. But it's also important to have a sensitive test so that you aren't missing people early in that time point of being infectious. We looked at these CT thresholds early in our testing. We had performed a bunch of testing in nursing homes, about 30,000 or so individuals who were residents or staff of nursing home. And we did observe something that had been seen before, that asymptomatic people have a viral threshold distribution very similar to those who have symptoms. And this really drove home and underscored the reason for having frequent testing of even asymptomatic individuals to spot them early. Or to spot them before they were infectious. And so this idea of really testing both symptomatic and asymptomatic is really what drove a lot of our need, I think, to scale up this test. So I want to talk to you a little bit about the scale and how we did it, just a few things. So we realized pretty early on that a lot of the problems of the traditional sort of testing labs were experienced were as follows. There was a very unconstrained front end with lots of tubes and lots of swabs and lots of different types of labeling. It was very hard to really automate. There was a lot of manual work. And then on the downstream end, there was a very high dependence on specialized kits. So sort of these one-touch machines where you loaded the sample in, you loaded the kit, you pressed the button and you got an answer. Now that's great when the supply chain is there, but if you run out of these kits, you really can't perform the testing. So we sort of turned that problem on its head. We insisted on the front part of supplying our own swabs and tubes and our own labels so that when these come into the lab, they're handled in a completely automated way, on automated sort of systems where they're reading the barcodes. There's no human touching or human decoding of these samples. And then on the back end, we completely used a set of off-the-shelf sort of modular processes and equipment, these items that we had available to us and that weren't part of this supply chain problem. So it's Hamilton robots, Agilent Bravo robots. We buy all the reagents in bulk for the PCR, and we perform the detection on easy to obtain thermoquant studios. We also have a lot of work design principles of how work flows through the lab and have been really tuned to have at least a 24-hour turnaround time. And I will show you that those industrial work design principles that we had been applying since the days of the Human Genome Project have really led to a smooth and predictable turnaround time. So here I'm plotting for you over the last month what we have achieved in terms of sample into the lab and the result out. We're under 12 hours now in terms of return of result. And we also very closely measure what % of samples we do return within 24 hours, and it's nearly all of them. I want to touch on sequencing now, since this is a genomics lecture and we are a sequencing lab. So we have turned our attention to viral sequencing. I'll show you this table, which might remind you of the one I showed you earlier about the situation of testing. And really the effort in the US was lagging. This is as recently as February, where we were seeing that the US was testing as little as 0.3% of coronavirus cases. And this is compared to other smaller countries that had much less coronavirus present, but we're still doing a far better job, I think, in getting cases sequenced. So we have turned our effort to supporting this now. We had a big interest in building this sequencing capacity here because we have the testing lab. So the samples are here. There's a really good representation of New England in terms of positive samples in our lab. So we did set up this capacity now. It was kind of tricky because we had to go back in and find those positive samples out of our testing operation, just to give you an idea of what that's like. So every day we retain about 1,000 PCR, or 1,000, I should say, 96-well plates of samples that are in their lysis buffer. We then worked out a system and built some logic in of how we would go out and cherry pick just those positive samples out of the plates. We select samples that have a cycle threshold value of less than 30 right now, so that there's enough in RNA for sequencing. These are being extracted in the same way they're extracted prior to the RT-PCR for the diagnostic. And then we transfer for them to another lab for PCR and library construction. We actually had to find a new building to do this because we were really concerned about contamination occurring here in the lab where the diagnostics is. The process itself is using the NEB Arctic protocol. And right now we're processing 2 384 well plates a day for viral sequencing. And then the sequencing itself is actually quite straightforward. We're actually able to multiplex together 384 samples on a single lane of a NovaSeq to achieve adequate coverage of the viral genome, which is fortunately quite small. So we're scaling this up, and Bron will tell you way more about this. We're working closely with the State Department of Public Health, the CDC, and other academic partners. I'm sorry, that's my time. As I said, we're really aiming to have this extensive coverage throughout Massachusetts and New England. Our goal is to test at least 5% of positives to have power to detect new versions of the virus should they emerge, and less over time as cases go down. And we're reporting these findings to the state DPH, to the CDC, so it's made available to the public. We expect to be at a capacity of 5,000 viral genomes per week by the end of this month. And this data is made available through this website here, auspice.broadinstitute.org. With that, I'm going to hand it to you, Bronwyn.
Awesome. Thank you, Stacy. And before I get started, I just wanted to take a moment to say, hi, Canada. I am a Canadian, though I'm seated here at the Broad Institute in Cambridge, Massachusetts. Now, I actually spent most of the pandemic working from my parents' basement in rural Nova Scotia, and have been following the trajectory of the pandemic across Canada closely, as well as following it in the US and in fact across Africa as well and around the world. So just picking up where Stacy left off there, I think just as variants of concern were really emerging as a threat to the progress the world was making in terms of the pandemic response, this story from the Washington Post came out that really shined a light on just how poorly the US was doing with respect to genomic surveillance broadly. And I think a combination of the need, obviously, to be doing more of this work and a heavy dose of American pride. The US government and the CDC have really stepped up to try to increase the level of genomic surveillance and really integrate it into the pandemic response in this country. So this graph that I'm showing you shows what that initial part of the scale-up looks like in the US. As you can see, these are week-over-week numbers of total genomes across the country. And this particular graph shows the breakout of what the state public health labs are doing. And I thought that might be interesting for folks working at BC-CDC and other provincial public health jurisdictions. But the overall kind of initial part of the scale-up has really been focused across the country on coupling sequencing capacity to large-scale diagnostic operations. And of course, as Stacy said, the Broad is one of those. And we were in the unique position compared to other more canonical testing labs that we're actually kind of a sequencing institute first and foremost. So rather than many labs struggling to really stand up the sequencing dimension of this work, this is something that Stacy's operation was able to do fairly seamlessly on the back of this amazing testing program that they had created. Over the coming months, once we really get numbers on the board, the CDC will be focusing on continuing to build out the public health lab component to decentralize that sequencing and get more and more of it happening at the state level and closer to the communities that are affected. And then of course, the CDC is also enabling academic partners to add capacity and to bring kind of the scientific dimension, the continued research focus of this work. I just wanted to flag that we have made some progress against those numbers reported in the Washington Post in December. So the US is now sequencing 1.14% of cases. It doesn't seem quite as significant as we would like to be, but those are hard-fought gains against just a huge number of cases across this country. But of course, we're still lagging behind Canada in terms of total percent cases sequenced at 1.57. And we're both, I think, just in awe of the efforts that's been stood up in the UK, the real gold standard for this operation at about 8 or 9%. And here I just wanted to show you how this is breaking out kind of across the country. The effort is zoned into 10 regional surveillance zones that are essentially health and human services jurisdictions across the country. And I actually forgot to, neglected to copy the legend of what we're actually showing you in terms of data here, but this is showing proportions of variants of concern in these 10 jurisdictions across the country, where the kind of orangish, light orange color represents B117. I think we've seen across Canada and around the world, wherever B117 gets a toehold, it really takes over. And although there's certainly regional dynamics at play in terms of the relative contribution of that, that is the dominant lineage across the country. We're now looking at more than half of all infections in the US being B117 and about 70% being variants of concern. And we are, so our jurisdiction that the Broad is serving is the New England Northeast region. It's essentially New England plus the state of New York, not including New York City, which is its own jurisdiction in the US. And actually, just one other quick note I wanted to mention for those of you in this space, when I was pulling this graph last night, I realized that it was only reporting data on the CDC dashboard through April 10th, about 3 or 4 weeks ago now. And I had a moment of frustration thinking, come on, we can do better. I want real-time data. But then I remember just how far we've come that we're reporting, not just in the US, but really around the world, these numbers in near real time. And it's just been tremendous progress for this field. Next slide, Stacey. And before getting into what we're seeing in New England and how we're working, I just wanted to take a step back and let you know kind of how we got here, and to share that we're really working not just in terms of sequencing and sequencing capacity at the Broad Institute, but really an end-to-end genomic surveillance system that is deeply integrated into state and federal public health systems, very responsive to the needs of the state, and also through working in close partnership with the academic community here in Boston. And this just shows that before COVID came, obviously with these closely gathered unmasked photos, these are just some pictures of work we were doing at the Broad with public health labs across New England and extending to other states as well to do training in genomic sequencing and bioinformatics and being able to couple both of those things to public health questions and public health needs. And so this was, pre-COVID, I think in last year in kind of the very early spring or late winter of 2020, we were planning our next summer training, our 5th event for this community, where we thought we'd be focusing on West Nile virus and Lyme disease, tick-borne disease. But of course, we all pivoted to COVID quickly. But because we had this community and this network going, I think it just put us all in a stronger position to be able to work together and to really mobilize when COVID came to New England. Next slide. So what are we seeing? I think, these are state, each panel is a state. I'm sorry that the labels are small, but Massachusetts, Rhode Island, Connecticut across the top, and then Maine, New Hampshire, and New York across the bottom, showing the total variant of concern counts in stack bar plots on a weekly basis in the weeks really from December through to just 2 weeks ago now, represented here. And what you can see in each state is that, clearly the frequency of these variants has increased in all states. B117, the gold color is the predominant predominant variant, I'd say, in most states. And I think, this is generally true across the US and around the world. But of course, there are these regional dynamics. And just to call out a few, one example is the interplay between, in New York, in the lower right-hand corner, between the so-called New York variants, the B1.526 lineage, and its competition with B117 in that community. Just a few weeks ago, it looked like 526 was going to be the dominant variant there, and it's only over kind of recent weeks that B117 is really kind of seems to be outcompeting it there. But then interestingly, as you move north from New York up through New England, those dynamics kind of vary, and you can see this incredible kind of phylogenetic kind of interplay between these lineages at the state level. And then as you get as far north as Massachusetts, the relative abundance of the so-called New York variant is pretty minimal. And the dynamic here is more between B117 and P1, the variant first identified in Brazil. And I'll touch on that more in just a moment. Next slide. So of course, in addition to and what sometimes to us feels like the bean counting of known variants of concern, some of, I guess, the more kind of scientific interest is in surveying for emerging threats and variants of interest, or even variants that are just emerging as lineages and mutations to be aware of. And so we are working, with our academic colleagues, epi modelers, and kind of genome jockeys to be continually monitoring across the region for emerging threats. And this panel just shows you really what a kind of hairball mess that is. So while it's really easy to now to identify known variants of concern, the art is in predicting what is coming that we should be getting ahead of. And so here you can see these are variants that we're tracking based on increased transmissibility phenotypes. It's the easiest phenotype to be tracking at scale, and you can see so more transmissible variants are in the kind of upper right, towards the upper right of the plots, and there's some known knowns, B117, of course, P1 you can see there. You can see in Massachusetts, we have a single case reported last week so far of the B1.617 lineage, 0.2 here, first identified in India. I'll say that this lineage is not very prevalent or not known to be as far as we've seen across the US. I know it's a bigger kind of factor in several parts of Canada, and that's a situation I'm watching with close interest, both as a Canadian, as a genomic surveillance, genomic epidemiologist. But yeah, there is not much evidence for community transmission so far for the so-called India variant in the US, touch wood. That's something that we're watching closely, and of course deeply concerned about what's happening in India and what's driving the surge there. Next slide. And so this is just another approach that we're taking to get at not just lineages, but emerging mutations of interest and the constellations of mutations that are driving these complex phenotypes for COVID disease. And this is just showing, this is one plot that's showing just a ton of work that's happening in our data science group at the Broad, where they're developing new methods to dig through, to wade through just the incredible volume of genomic data that we now have globally to identify mutations that are associated with phenotypes like increased transmissibility. I think the real innovation here that I won't get into is just the ability to handle the data at scale. They're using Pyro-based modeling approaches that kind of go beyond the more traditional Bayesian approaches that kind of fall over at the scale of data that we're looking at now. And the things to flag here, so these are mutations that seem to be associated with transmission or with increased transmission, where the dots are scaled according to the effect size. And of course, we see several mutations in spike, many of our dear friends there that we've been paying a lot of attention to. But one thing that this model is pulling out are just a series of mutations in the nucleocapsid gene that really haven't been getting the attention that they may deserve according to the outputs of this model, at least. So something there to be keeping our eye on, both certainly within our community, but really within our global community who are looking at this. Next slide. I wanted to just quickly come back to this P1 story that I mentioned in Massachusetts, both because it gives just a great illustration of this end-to-end genomic surveillance system that we've established here with all of our colleagues, but also out of solidarity with you in BC and in Vancouver. When P1 first arrived in Massachusetts, it was almost concurrent with the outbreak in Vancouver. And so I was just constantly keeping my eye on both sites and seeing what we could learn by what was going on in BC, because it was just kind of one step ahead on the introduction and community spread of P1 right behind Massachusetts. And so what you're looking at here, I mean, just the story really quickly of what happened here was that there was a kind of a surge in cases in Cape Cod on the Massachusetts coast, and no sense really of what was driving that. That was just as we were kind of ramping up our genomic surveillance capacity. And so the state public health department reached out to us to sequence cases that seemed to be associated with a cluster there, and we quickly determined that they were in fact a cluster of P1 outbreak on the Cape. And that just required all of those pieces that need to like work in lockstep to make this work in real time and really be useful. Public health seeing the problem, increasing testing, doing targeted testing around the cluster, those samples being tested at the Broad in the team that Stacey leads, that team then pulling out, cherry picking this handful really of about 60 samples of positives in the first set out of the hundreds of thousands of tests they're running every day for sequencing, getting those sequenced in a matter of about 48 hours and identifying that this was in fact P1. And then in terms of the public health response to that, of course, they dramatically increased the community surveillance for testing and sequencing in that region, targeted more aggressive vaccine campaigning. And just one other note, I should mention that Massachusetts has the highest community, highest numbers of expat Brazilians outside of Brazil, in fact. And so there was the public health element of communication and stigma and issues like that was also at play. And so what this data showed was that, yes, this surge was being driven by P1 on the Cape, but in fact, there were multiple introductions of P1 into Massachusetts. And while one of them did seem to come from Brazil, the rest of them came from other sources, including other domestic sources and other countries in Europe, actually. And so it helped them to kind of manage that public health messaging around stigma. Next slide. I'll just quickly say that we've also been developing a system for cloud-based data management, analysis and sharing, leveraging the work that the Broad Institute has done to manage human genetic data over the years. And this has caught the attention of the CDC. So we were using it for our operation, but now the CDC is deploying this across the country. So far, it's in 28 public and state and local public health labs to help kind of build a common ecosystem and harmonize methods for data analysis. So that's just another piece of work that we're proud to be contributing here. Next slide. And so finally, just a few thoughts. I just want to wrap up so we have time for questions, but just around how we work. I think we've hit on many of these points, but we think a lot about sampling strategy, trying to be representative, but also targeted where needed. We're really working to cut down turnaround time. It's around 7 to 14 days on average, but when needed, we can really light that up and get it done quickly. We're reporting weekly to the DPH and CDC, and then really trying to build, and in fact, building community both as part of the national Spheres network in the US for this genomic surveillance community nationwide, and then also have kind of a subgroup of that meets weekly in the Northeast to look at these emerging and known variants and to connect those into the research community to do that kind of functional follow-up and epidemiological modeling and connection to cohorts like vaccine escapes and longitudinal long-term COVID infections. And then just my last slide. And then just zooming way out, and we just love to think with you all about both the challenges that we still face and that I think we could be working on together and the opportunities for this space. I think it's clear that COVID is a watershed moment for genomic surveillance, but there's still much to be done to really robustly integrate this into public health and to make it both preventative as well as responsive. And these are just some thoughts that I have in terms of what is still needed in this space, but I'm sure that this will come up in the discussion. And then just finally to close, just want to acknowledge this is just a snapshot of everyone who's involved in our work and the people that and groups that we're working with across New England and really throughout the country. And with much gratitude to GISAID and NCBI for hosting our data and making it accessible, and to the funders who support the work. Thank you.
Stacey and Bronwyn, thank you very much. I mean, this is spectacular, evidentiating so many of the things that we all talk about that we know are important, from the capacity building, the methods building, the partnership between academia and public health that you so well illustrated, but also the network that you've built. I have a few questions for you, and so I'll start with this question that has been voted up for you, Stacey. What is the CT threshold used to call a positive? Should the threshold have been lower or higher, and how would this have changed the public health measures?
That's a terrific question. Our CT threshold is 40. On the upper is that's where we cut off, and yeah, we tried we tried lobbying for a while to provide guidance based on CT threshold for individuals, but the feedback we continually got both from the Department of Public Health here and the CDC was that there was just lacking clinical data at the time to be able to definitively give guidance based on CT threshold. Had the right study been done, had we had enough time, right, to do the right study and correlate true infectivity with CT threshold, maybe that would have been a different story. But yeah, we have to call everything positive right now. But I will say we do make available the CT threshold. So if anyone calls us who's given a positive result, we have a very easy way to look up what that is. And indeed, some of the nursing homes, I believe toward the end, have now started to sort of base their decisions on what they do with patient management based on that value. But it's a tricky thing.
Thank you, Stacey. And then one more question, because we tight on time, but for Bronwyn, which also was one of my questions, but they have asked. I particularly praise the partnership between academia and the public health, because I think this is a theme that is resonating in other countries, particularly in the UK. But did you find any resistance by your public health partners in releasing information or data, for instance, to the common GSAID platform or similars? And if you did, how did you go about overcoming that?
No, I think I'm trying to remember early days of the pandemic if this was an issue, but I don't think so. Not in terms of release of the genomic data. That is something that, because we had this work, going prior to COVID, they were just used to that concept and they knew the importance of data sharing at that level. So I would say no in terms of sharing genomic data and kind of minimal metadata state and date of collection into public repositories. It is still a struggle for us working, with them to, it's not a struggle, it's more, I'd say more of a technical problem really, to integrate the genomic data with epidemiological metadata. Not always can we share that data publicly. We understand that, and we're fine with that. But actually, just working across the systems and getting kind of joining up their databases with their genomic data is tricky. And I think that that's one of the things that we as our operation and collectively, I think we need to be able to navigate to move the needle. And what we can really do with genomic data is closing the gap between the epi data and the genomic data itself.
Well, thank you very much. And I think we are running a little bit out of time. I know that probably the organizers are going to kill me now, but there is one question that keeps coming back. And so a really quick answer. How do you select your samples? Are they randomized for sequencing?
Should I take that, Stacey? Or so we're now in the fortunate position that we're able to sequence most of the positive samples that are coming through the pod, coming through the testing platform at the Broad. We have been doing kind of a balance, or trying to strike a balance between about 80% surveillance sequencing, but saving 20. So that's kind of representative sampling across geography and across incidence. but then saving about 20% of capacity for responsive sequencing to cluster investigations or other targeted epidemiological questions or public health questions.
I want to thank you both. This was phenomenal, and we know that these solutions that we all find in our own nations need to eventually find their way to a global solution. So I think that sharing this was phenomenal. Thank you very much.
Thank you. Appreciate it.